Assalamu alaikum. Today, the topic of my lecture is hypertrophic cardiomyopathy. It is the second cardiomyopathy. The first one I've discussed in one of my previous lectures by the name of dilated cardiomyopathy. Now, what is hypertrophic cardiomyopathy? It is a genetic disorder of cardiac muscle tissue characterized by abnormal thickening of cardiac muscle tissue without any other clear cause, usually involving interventricular septum. It is the most common cause of sudden cardiac death in young patients. Now, coming to the etiology, it occurs due to autosomal dominant mutations occurring in genes encoding the sarcomere proteins. The important ones are genes encoding beta myosin heavy chain protein, second, myosin binding protein C, and third, troponin protein. Now let's discuss the pathophysiology. It includes the following 3 points. Number one is asymmetric septal hypertrophy that leads to hypertrophic cardiomyopathy. Second is left ventricular outflow tract obstruction due to systolic anterior motion of mitral valve or asymmetric septal hypertrophy. The third one is diastolic dysfunction due to stiff ventricle and impaired relaxation that leads to diastolic heart failure, known as heart failure with preserved ejection fraction. Now there's this unique feature of left ventricle outflow tract obstruction, that is, it is dynamic, that is not fixed. Left ventricle outflow tract, it is encroached in these patients due to the increased size of interventricular septum, particularly evident during systole. Other factors that contribute to the left ventricle outflow tract obstruction are increased contractility, that is during exercise, which causes forceful contraction and therefore greater degree of obstruction. Secondly, decreasing preload, that is in cases of hypovolemia, vasodilation, tachycardia, thus increasing the obstruction. Now, if you remember this formula, it will be easy for us to answer questions in exam. That the formula is left ventricle outflow tract obstruction is inversely proportional to the volume of blood in left ventricle. Now, let's put in the example of preload in this formula. That is, if we increase the preload during like squat or leg raise, the volume of the blood in left ventricle increases. So the ventricle size increases. Therefore, the obstruction, it decreases. Now, if we decrease the preload, that is during Valsalva maneuver or standing, the volume of the blood in left ventricle decreases. Therefore, the ventricular size, it also decreases. Hence, the left ventricle outflow tract obstruction increases. Now, coming to the symptoms of hypertrophic cardiomyopathy, they are exertional dyspnea, exertional chest pain, palpitations, syncope, fainting or dizziness, and sudden cardiac death. The signs are double apical pulsation, pansystolic murmur, jerky carotid pulse, and ejection systolic murmur. The intensity of ejection systolic murmur is decreased when left ventricle outflow tract obstruction is decreased, such as during squatting, leg raise, and it is also decreased while sustained hand grip. And the intensity of ejection systolic murmur is increased when left ventricle outflow tract obstruction is increased, that is during Valsalva maneuver or standing. Now let's discuss the investigations of hypertrophic cardiomyopathy. The first investigation is ECG. The findings in ECG are left ventricular hypertrophy, T wave inversion, and septal Q waves. The second investigation is echocardiography, which is the gold standard. The findings are septal thickness is greater than 15 mm, systolic anterior motion of mitral valve, and left ventricular outflow tract gradient. The third investigation is cardiac catheterization, and one of the most important signs that we see during cardiac catheterization is Brockenbrough-Braunwald-Morrow sign. Now, let's discuss the management of hypertrophic cardiomyopathy. The management is of two types, medical and surgical. Now, first, let's discuss the medical management. The first class of drugs included in the medical management are beta blockers, that are the first line drugs. Then come the calcium channel blockers and disopyramide, which are the alternatives of beta blockers. The third is symptomatic treatment, that is amiodarone in case of arrhythmias, anticoagulants in case of atrial fibrillation, and implantable cardiac defibrillator in case of syncope or dizziness or fainting. The surgical management includes alcohol septal ablation, surgical myomectomy, dual chamber pacing, and the last, which is transplantation. Thank you so much. This was all for the topic of hypertrophic cardiomyopathy. For more videos, kindly subscribe my channel. Thank you.